Just let me just press recording. So most welcome. It's actually 7 p.m. I think we can go ahead and start. We're expecting around 50 of us. We're currently at 15, which is fine. I hope the rest will find us along the way. Yes, so most welcome. We are very glad to have you this cold evening as quality care. We are psyched to resume the CME series. I know we haven't had CMEs for I think 1.5 months now. So many people are calling me, Edgar, we need these CMEs. Edgar, we need these CMEs. We just want this knowledge and skills. We really need it. Yes, but most people want the CPD points. Yeah, most people want the CPD points. So most welcome to the trauma CME. Today's focus is of course thoracic trauma. Specifically for this CME, we'll be earning 5 CPD points for doctors, for nurses, and for clinical officers as well. For other medics like CNAs, paramedics, yes, and one last one I don't remember. Yeah, unfortunately, we are not yet offering CPD points for you, but you can still upload your certificate. So we'll be issuing a certificate for those of us who are not appearing over here. So medical officers, nursing officers, or clinical officers. In case you're not appearing there and maybe you'd want to just try your luck in gaining those CPD points. Yes, people have done that in the past and gotten 1 or 2 CPD points, so no guarantees for you. But for medical officers, you will get 5 CPD points. For nursing officers, we will issue you with a certificate which you will upload on the NCK portal. Yes, you upload it on the NCK portal, and fingers crossed for you, you do get the 5 CPD points. So, like Edgar, why are you saying fingers crossed? With the NCK, it depends. It depends. But most of the times, let's say 70% of the time, you will get 5 CPD points. So in case you don't, we will talk to the necessary people, and hopefully you will be allocated those 5 CPD points. For clinical officers, please bring your logbook to be stamped at our offices. So please do not forget to do that. So yes, we do have a number of courses as quality care. Many people ask if we offer advanced trauma life support. Unfortunately, we do not offer advanced trauma life support. Yes, let me just say that regarding advanced trauma life support. However, we do offer a course called pre-hospital trauma life support. So what would be the benefit of doing PHTLS? Now, PHTLS has a number of benefits. If you're a medic, possibly you want to become a flight doctor, you want to become a flight nurse, must have done PHTLS. You want to work with Doctors Without Borders, MSF, must have done PHTLS. Possibly you want to work in those cruise ships that go out on sea on holiday for extended periods of time, then you must have done PHTLS. So what does this PHTLS entail? Trauma life support, pre-hospital trauma life support, specifically focuses on, the pre-hospital patient. But of course, even if you are managing the pre-hospital trauma patient, they are still a trauma patient. So just in case you do deal with a lot of trauma patients, or maybe you work in a facility that is on a major highway or on a major road, then for sure, accidents are prone to happen and you will get trauma patients. Now, for example, here, we are turning the patient. Of course, as you turn the patient and maybe you're looking for injuries on the backside of the patient, you want to do so as one team because trauma patient, of course, has many injuries for one spine injury, neck injury. So if you're managing a trauma patient, you really have to work as a team, as our participants here are working as a team. Here we were simulating like a road traffic accident. Maybe you're in your car. God forbid the worst happens, in an RTA, you as your patient will get. Sorry about that. There's a lot of traffic here. Yes, so trauma patients will most likely get spine injuries and neck injuries. So training on how to immobilize your patient. Here we have something called a vacuum splint. Yes, so you mobilize a fracture. Your patient has broken bones. You don't know what to do. You can't place a cast. Then you use the vacuum splint, stabilize your patient, immobilize their leg or, yeah, and then move them. And of course, with the trauma patients, you want to deal with immediate life threats. So of course, you want to secure their airway as soon as possible. Intubation is a skill that you should really have if you are managing trauma patients. And we do cover it in pre-hospital trauma life support. Here we were doing drills, for the pre-hospital team, called the hospital, simulated an accident somewhere, timed the time the ambulance took from hospital to scene of the accident, management of the patient on the scene of the accident, and then back to the hospital. So in case you are working in a facility that would really benefit from trauma life support, we encourage you to share the knowledge after this training, or rather the CME. Very important to do so. And yes, we are launching our Life is Why campaign, but it's never stopped. It's always continuing. So in case you are working in a hospital that would benefit from a trauma life support CME, please invite us. We will come along and hopefully share some knowledge and skills that will be beneficial. We have a number of courses. Of course, PHTLS is one of them. Again, if you deal with trauma patients, very, very important to do this course. Hopefully, it will help you manage your patient better and give them the best chances of survival. We have other courses as well. BLS, ACLS, of course, being the most popular one. BLS, ACLS will be having it on Thursday, starting on Thursday. Right. So thank you so much, guys, for joining us. We are very glad to have you with us. So now I will hand it over to our speaker for today, Eric. Eric is an American Heart Association instructor, a trauma instructor, and a National Association of Emergency Medical Technicians, a POCUS instructor, etc. We're hoping that the session will be beneficial to you. In addition to gaining these CPD points, of course, we also hope that you benefit in terms of knowledge and skills. We'll have a Q&A session at the end. In case you have a question, please post it in the chat. And then after the session, we will have a discussion on the same. Otherwise, thanks so much for joining. Let me hand it over to the speaker for today. We are very glad to have you guys. Mhm. All right, so just a minute. Eric is taking over shortly. Thank you.
Uh, Evening, guys. My name is Eric, as Edgar has shared. I'm sure we have interacted with quite a number of you um, in different fora and possibly different classrooms. Now, for tonight, we are just going to discuss thoracic trauma when it comes to the emergency department. So, your initial encounter with thoracic trauma could even be out of hospital. Maybe you are acting as a good Samaritan and you come across someone who has undergone or has suffered from thoracic trauma. Now, the mechanisms through which someone suffers thoracic trauma, there are two majorly. So they can have penetrating trauma due to things like stab wounds, gunshot wounds. You may have impalement or blunt force trauma. That's the second mechanism. So blunt force trauma, of course, the most common being due to road traffic accidents. Others could be due to assault and falls, of course. This can then lead to certain key injuries that we are going to discuss. They include lung contusion, flail chest. Now, of course, because of time, we won't discuss all of them, but we will mention some of them in passing. An open pneumothorax, cardiac tamponade, rib fractures, a simple pneumothorax, a tension pneumothorax. We have others like commotio tracheobronchial injury. We have diaphragmatic rupture with herniation and things like that. So in greater detail, the list then includes issues such as commotio cordis and traumatic aortic disruption, among others. Now, when it comes to a lung contusion, then here we are saying due to the traumatic injury or blow to the chest, particularly with blunt force trauma, the person may develop a lung contusion, and this majorly will occur post having been transported to your facility. So, with your RTA patients who have suffered thoracic trauma, you have to watch out for lung contusions because this will mean there's inflammation and, of course, leakage of um, fluid from the vasculature into your alveoli, which will then greatly diminish gaseous exchange. So, with a lung contusion, one of the key findings will be uh, crackles. Crackles. Okay. So, when you do your auscultation, you hear crepitations or crackles. So that would suggest that possibly your patient has developed a lung contusion. Remember, our main objective in the ED would be to optimize oxygenation, to optimize oxygenation and ventilation. So because we don't have specific slides discussing this later on, that's why I'm touching on it. So when you do your complete assessment, this patient will likely have crackles and a decreased level of saturation. So when that is the case, then one of the ways that we can consider managing such a patient is non-invasive ventilation. Non-invasive ventilation would then entail possibly CPAP or BiPAP, okay? And if this fails, of course, you will then consider intubation and then consider using positive end expiration pressure, among other things, all right? Aiming at enhancing oxygenation and ventilation. That is a lung contusion. So after a few hours, you have to be on the lookout for something like a lung contusion. The second common one would be rib fractures. Now, rib fractures, we don't have content on it here, but I will touch on it. One of the key predictors of the outcome would be the number of ribs that are fractured. And the best way to assess for rib fractures is palpation. So you must palpate the ribs for continuity. So you palpate for continuity. You also want to check for crepitations when bony fragments are rubbing against each other. Okay, so crepitations. You also possibly want to assess for point tenderness, the point at which there's the rib fracture, there will be tenderness. Other than the number of fractured ribs, the location of the fractured ribs would also be a good indicator of whether or not you have to worry about further injuries. If the patient has rib fractures affecting the upper ribs, then typically it would mean that the amount of force, because the upper ribs have cushioning, you have the musculature that protects the ribs as well as the shoulder girdle. So if the upper ribs are fractured, then it means that the amount of force that caused the fractures was significant. So you must be worried about other internal injuries, particularly things like a pneumothorax due to a ruptured alveoli or things like that. So rib fractures. Now, with rib fractures, the key initial management would be to focus on pain management. Because when someone has a fractured rib, then they tend to try and breathe shallowly so that they don't experience the pain. So unless you do proper pain management, then your patient's ventilatory status will be affected. All right. So pain management is key. Now, one key thing we must understand in our initial management of rib fractures is we no longer uh, use restrictive bandaging or dressing. We do not use restrictive dressing because that affects chest wall expansion in a patient who is already compensating, they're breathing shallowly. So if you put restrictive dressing, then you will end up with ventilatory issues. So those are the first two. We don't have them as specific slides that we are discussing a bit more on. The last three as well, we do not really have much on them in terms of the slides. Now, when it comes to your diaphragmatic rupture, of course, imaging would be your best approach to confirm if you suspect herniation to have occurred. When it comes to commercial cordis, now for commercial cordis, we are just saying this is whereby a sudden blow to the chest results in what? In disruption of the heart's electrical activity. That stimulus, that impact lands at a period during vulnerability when it comes to the heart's electrical activity. So it comes during a period of repolarization. So if the patient suffers a blow to the chest, particularly to the heart, during a period of repolarization or the vulnerable period, then they can develop ventricular fibrillation. So they will go into a cardiac arrest. And this is an injury that is quite common as well with sports. It's a common sports injury. Someone just suffers a blow to the chest and boom, they go into a cardiac arrest. So the rhythm, the culprit here is usually ventricular fibrillation. And that is why any thoracic uh, trauma patient, any patient who suffers trauma to the thorax, we must attach them to an ECG. We must, at the very least, do cardiac monitoring. Cardiac monitoring would also help us pick up on things like your cardiac tamponade. So always ensure you do cardiac monitoring or ECG on your patient. Management, of course, defibrillation. All right, we won't talk about that much. The other catastrophic injury that typically doesn't make it to hospital is traumatic aortic disruption. Such patients will likely bleed out on the scene, or even if they make it to hospital, they will never make it. It's unlikely that they will make it to the theater. Now, when it comes to the assessment, because you can't manage what you've not assessed, when it comes to the assessment, under breathing, okay? So the first thing that you'll do is, of course, observation. What are you observing for? So, of course, check the respiratory rate of the patient, check the rhythm with which they are breathing. Is it regular, irregular? Because when it comes to trauma, a traumatic brain injury may be present, and that would affect the rhythm with which they are breathing. Assess for added sounds. So we say quality, uh, that is under listening, sorry. So forget about that one. Sorry, just a minute. Yes. So when it comes to observation, you can observe the rhythm. You can also observe what depth. You can observe whether both sides of the chest are rising equally. So you want to check the symmetry of chest rise because one of the key complications of thoracic trauma is a tension pneumothorax, in which case there will be asymmetrical chest rise. You want to assess the effort. Do we have increased work of breathing? You also want to, of course, check things like jugular vein distension. You want to also check for tracheal deviation. And then if you are observing the chest, you can also observe for paradoxical chest movement. Paradoxical chest movement will typically occur with a flail chest. So do we have any segments of the chest that are moving in the opposite direction? That is what we call paradoxical chest movement. If you have a segment that when the patient breathes in, that segment collapses inside. Because when we breathe in, our rib cage moves upwards and outwards typically. So that segment collapses inwards. That would suggest that you have paradoxical chest movement. Now, when it comes to uh, auscultation, of course, we know that we will be listening for added sounds. Are there any added sounds? Though we can also hear any added sounds or any audible added sounds. When it comes to palpation, we've already mentioned quite a number of things that you will check. So you'll check chest wall expansion. Under auscultation, you'll also listen for heart sounds. So always auscultate heart sounds so that you're able to hear any murmurs and things like that. So palpation, chest wall expansion, of course, point tenderness, which we said would possibly suggest a rib fracture. You can also palpate for crepitations. So if the bony fragments are rubbing against each other. Percussion is not something that you'd be able to do typically in the field or even in a hospital setting where there's a lot of noise. But for percussion, we would possibly be looking for hyperresonance or dull sounds. So hyperresonance would be if we have a tension pneumothorax. Dull sounds would typically occur if we have a hemothorax. All right. So that is assessment for breathing. So look, listen, feel, of course. All right. Now, additionally, if you are in the emergency department, you must be worried about exsanguinating. So exsanguinating hemorrhage, or what we would typically call catastrophic hemorrhage, because that will kill your patient fast. So when you get the patient, the first thing you want to have a complete global assessment of this patient. 360. Do we have any active bleeding? If we do, that is what you must address first before you even go to the airway, the breathing, and all that. Now, thoracic trauma can also affect the airway, but for today, we'll focus on injuries that will particularly be around the thoracic region. Now, secondary assessment, we are saying signs and symptoms, allergies, medications, past medical history, last meal events, And then this is for risk factors. Any trauma patient who is obese, so we call them bariatric patients, bariatric patients, your approach to assessment must be different. Any pediatric patient, your approach to assessment must be different. Any obstetric patient, your approach to assessment must also be different. It's not within the today's scope. We won't discuss it much. But when it comes to risk factors, think medications that this patient may have been taking that may predispose them to injuries. Geriatric patients as well. So add geriatric patients to that list. So geriatric thoracic trauma, we are worried because of osteoporosis. So such patients are predisposed to their ribs can fracture easily, and that could then lead to pneumothoraces and things like that. So when you're doing your secondary assessment, also bear in mind the special considerations or the risk factors. Do a complete head to toe, of course, but if there's thoracic trauma, concentrate a lot more on the chest. Other than that, we also have pulse oximetry, of course. We have waveform capnography. We have extended uh, focused assessment with sonography in trauma. We have x-rays, of course. These are obvious ones. I didn't feel like adding them here. We have maybe a CT and MRI, among others. Now, I felt I needed to particularly mention fast because it is something that is currently coming into the market. So in the emergency department, we can quickly rule in or rule out a pneumothorax thanks to things like lung sliding. So when you do point of care ultrasound, you are taught about something called lung sliding. When you do the ultrasound, this just looks like shimmering on the pleural lining. So when you see that shimmering, it means the pleura are rubbing against each other and moving against each other. That is usually absent when we have a collapsed lung. So it has a 90% accuracy when it comes to identifying a pneumothorax. All right. And the presence of lung sliding, if lung sliding is there, then it means your patient, at least at that point where you've done the ultrasound and seen lung sliding, they do not have a pneumothorax. Additionally, the extended fast can also help us identify free fluid within the pleura. So blood within the pleura would then suggest a hemothorax. And then when you do your subxiphoid view, you're then able to see and determine whether or not there is the presence of a cardiac tamponade. All very important pathologies when it comes to trauma. Our primary concern before we even get to aspects like tension pneumo and tamponade and okay, tension pneumo we get to it urgently, but before we get to things like contusions, rib fractures and all that, the main reason why we are worried about a thoracic trauma patient is because of reductions in tidal volume. Now, the reductions in tidal volume can occur due to obstruction, which we said will not discuss airway issues, but the presence of an altered mental status, as in TBI. But we are worried about movement of air in and out of the lungs. This movement of air in and out of the lungs can be affected by the first two, but can even be affected by something as simple as broken ribs. So you must assess your patient completely. Okay? When it comes to observing the depth of chest rise, do it. When it comes to palpating for point tenderness and continuity of the ribs, do it. Or crepitations, do it. When it comes to assessing for a pneumothorax, initially it could be a simple pneumothorax, which then complicates into a tension pneumothorax. Of course, the emergent situation would be the tension pneumo, but if you catch it early, it would even be better. Paralysis of the respiratory muscles, once again, injury possibly to the cervical spine. So here we are saying, even as you, because Edgar mentioned, as you move the patient, you must be mindful of their C-spine. So someone must constantly be maintaining uh, what do we call it? Manual inline stabilization of the neck. However, we are not saying go overboard. If the patient, based on your possibly nexus assessment, you determine they do not need a C-collar and you've done imaging and ruled out a cervical spine injury, then there's no longer any need to do your manual inline stabilization or immobilization of the C-spine. Unstable or perforated rib cage, we talked about an open pneumo, all right? So, or things like, um, what do we call it? The name escapes me. So we are talking about a flail chest. Yes, that's what I'm looking for. So things like a flail chest as well, an unstable rib cage. Now, more complex oxygenation problems, as I said, will occur likely later on, but primarily the reduction in tidal volume is your primary concern. Now, this image highlights this. So when it comes to thoracic trauma, the first image is for a normal patient. Their SpO2 is normal. Their CO2 levels are also normal because their volumes or their tidal volume is normal. Now, if this patient suffers, say, a rib fracture, and they start to try to breathe shallowly so as not to cause significant chest wall expansion and worsen their pain, then their tidal volume will reduce. That will mean their alveolar ventilation will also reduce. When they have reduced alveolar ventilation, then this will manifest as a reduced SpO2, and that's why pulse oximetry is important, and a high CO2. Okay, so when you come across such a patient, of course, your initial intervention, if they are breathing adequately, is to put them on oxygen. So when you put this patient on oxygen, then image C comes up. The oxygen, supplemental oxygen, will correct their SpO2. Their SpO2s will return to normal, but their CO2s will remain high. So you will have hypercapnia. And patients who have suffered multi-system trauma, hypercapnia can be detrimental. So for a patient who has a TBI, for example, if we get hypercapnia and the central chemoreceptors recognize this, or we have hypercarbia, okay, excessive CO2 levels or elevated CO2 levels in the blood. When you have elevated CO2 levels, PaCO2 is high, then what happens to cerebral blood flow is that we end up with vasodilation. So when you have vasodilation in the brain and this patient already has a TBI, then that will worsen the traumatic brain injury because the hematoma is more likely to expand much more rapidly. So you have a lot to worry about when it comes to the effects of trauma on ventilation and oxygenation. So in addition to correcting your SpO2 levels, you need to start thinking about your elevated PaCO2 levels, especially in a patient with a TBI. However, unless if a TBI is not there, then having normal SpO2s would suffice initially. However, there are circumstances where, due to the nature of the injuries, tidal volume drops significantly. So as we can see in image D, when tidal volume drops significantly, despite you giving this patient supplemental oxygen, they are actually in what we call respiratory failure. So because they are now in respiratory failure with significantly reduced tidal volumes, then you will end up having reduced SpO2s despite supplemental oxygen and increased CO2 levels. So such a patient who saturates poorly despite high flow oxygen, such a patient will require assisted ventilation. So you will not just put them on a non-rebreather or a simple mask or whatever. They will require assisted ventilation. Assisted ventilation meaning they will require positive pressure ventilation. You will need to add that tidal volume yourself. So positive pressure ventilation. Any thoracic trauma patient who is saturating poorly despite high flow oxygen and they have elevated CO2 levels will require positive pressure ventilation. Now, if you are assisting ventilation, then it also means that you will need to consider advanced airway management. All right. So be on the lookout. Initially in these phases, initially in B and C, typically these patients are in respiratory distress. They're in distress because oxygen supplementation can work. But once you get to a point where oxygen supplementation is not effective, then you're likely staring at respiratory failure. Now, when it comes to the initial management for the common injuries that I listed there, the flail chest, for a flail chest to occur, the rib must be fractured in at least 2 points. So you have 2 points that are not attached to the rest of the rib cage. So that then leaves you with a segment that is hanging. That segment will typically be moving inwards during inspiration and moving outwards during expiration because intrathoracic pressures will fall during inspiration, meaning the segment will also fall in together with the intrathoracic pressure. Because pressure inside has fallen, it drops within. When you breathe out, when the patient breathes out, pressure within the thorax rises, and therefore the segment then moves outwards. Our key management is pain relief. Now, as you do your pain relief, you're then watching your SpO2s, of course, and you're watching your CO2s so that you determine the need for ventilatory support or, at the very least, supplemental oxygen. Additionally, we will do pulse oximetry. We will not do restrictive dressing. So restrictive dressing was previously practiced. Now we no longer do it. Majorly focus on pain relief until we can get definitive management. Patients who have suffered things like gunshot wounds or stab wounds will typically have an open pneumothorax, what we call a sucking chest wound. Now, sucking chest wounds, the key or the recommendation is that we do a vented chest seal. So you cover it with a vented chest seal so that during inspiration, the vented chest seal prevents air entry. During expiration, the vented chest seal has a one-way valve that allows for escape of air. Now, if you're in a setting where you do not have a vented chest seal, Tom have said we no longer practice restrictive dressing in a flail chest or even rib fractures. So restrictive dressing, before we would dress the patient all round to try and stabilize the free segment. But now we no longer do that because it can cause reduced chest wall expansion and worsen your ventilatory status. Good. Now we were in an open pneumothorax and we call this a sucking chest wound. For a sucking chest wound, you can have your vented chest seal or you can do an occlusive dressing. An occlusive dressing is anything that does not allow passage of air. So it could even be these packagings for, say, gauze, sterile gauze. Just the packaging, the plastic part, the paper bag. You tear it and then you place it on the patient's chest and then you tape it on three sides. So you tape, you tape, you tape. That then leaves this lower bit where when the patient breathes in, the dressing collapses, sealing the open sucking chest wound, preventing air entry. When the patient breathes out, this dressing will allow for air to escape, but it does not allow for air entry. Due to the sucking nature of the wound, it sucks the occlusive dressing onto it, closing it, sealing it, preventing air from leaking into the pleura or the pleural cavity, causing attention physiology. Now, for patients in whom you have this kind of occlusive dressings, watch out or monitor for development of tension physiology. Development of tension physiology. Because of the nature of the chest seal, you may develop a tension pneumothorax. So watch out for tension physiology. Tension physiology, we are saying, your patient could have jugular vein distension. They will have decreased breath sounds. They will have asymmetrical chest rise, among others. So watch out for this. If a tension pneumo starts to develop or develops, remove your dressing to allow for air to leak out. You will undo your dressing to allow for air to leak out before reapplying it. And you will keep on watching for development of a tension pneumothorax. One of the key T's that we discuss even in ACLS is tension pneumothorax. So when it comes to a tension pneumothorax, the patient will not have breath sounds on one side, the affected side. They will have jugular vein distension. They may have tracheal deviation, but you must be aware that tracheal deviation is often a late sign. Okay, so even if, okay, so tracheal deviation will be a late sign. So even if the patient does not have tracheal deviation, but they have jugular vein distension, absent breath sounds, Asymmetrical chest rise. That patient will typically require needle decompression. And needle decompression, we will do it at the fifth intercostal space, anterior axillary line for the adult. All right. So for the adult, the recommended location for needle decompression using a gauge 10 to gauge 16 needle is the fifth intercostal space, anterior axillary line. All right. Be mindful that even after achieving decompression initially, your patient may still develop another tension pneumothorax. So you may have to repeat your needle decompression again. All right. So always be aware that even if needle decompression was, say, done in the field, they may develop another tension pneumo because your needle does not allow for sufficient escape of air. So tension can build up and result in a tension pneumothorax. Long-term management for this is, of course, chest tube insertion. But because the materials for doing this, the materials for a chest tube insertion can take time to gather. A thoracostomy set may take time. You can do a needle decompression urgently and then possibly do the chest tube insertion later on. Now, because of time, the other key type of injury that can result from thoracic trauma that you have to be aware of is your cardiac tamponade. So cardiac tamponade, pericardial tamponade, the fluid around the heart within the pericardial sac prevents expansion of the heart. So remember we said any patient with thoracic trauma, do an ECG. You will see low voltage waveforms on your ECG, particularly your QRS will be low voltage, okay, due to poor transmission of the electrical impulses to the surface. If you are already doing an ECG, jugular vein distension will be present. Jugular vein distension will be present. If the patient has a pulse, you will hear muffled heart sounds. So, muffled heart sounds. So, muffled heart sounds. I know we know about Beck's triad. Patients will typically also present with hypotension. So the triad is hypotension, muffled heart sounds, and jugular vein distension. Confirmation can be done using point of care ultrasound. So you'll see fluid within the pericardial space. Management for cardiac tamponade is typically pericardiocentesis, if within your scope. If not within your scope, expert consultation. Please, expert consultation. That is it for what we will cover today. Of course, we've mentioned other things like traumatic asphyxia. We have we've talked about diaphragmatic rupture. We've mentioned commercial cordis. We've mentioned rib fractures can also complicate your ventilatory issues. We've mentioned that your primary concern is oxygenation and ventilation, the tidal volume. If your patient's SpO2s remain low and their CO2s are high, consider assisted ventilation. Bag this patient. Management for the flail chest in the emergency department would be pain relief. Pain relief, always pain relief. And then, of course, where there's a need to do so, offer ventilatory support. So watch their pulse oximetry, watch their CO2s, and that will tell you whether or not you need to be more aggressive or you just need to maybe give supplemental oxygen. I don't know whether I have answered the questions that we had regarding the flail chest. So watch out for, so of course, do your proper assessment. What you're looking out for include things like lung contusions, rib fractures, a flail chest, a simple pneumothorax, or things like a hemothorax or a hemopneumo, an open pneumothorax, particularly with penetrating trauma, tension physiology, a cardiac tamponade. Now, more so diaphragmatic rupture with herniation, possibly. More serious issues that are unlikely to make it to the hospital include your commercial cordis or traumatic aortic disruption. I believe that brings us to the end. So I'll give it back to Edgar because of time. But of course, there's a lot more that we can engage on when it comes to thoracic trauma. But hopefully we've gotten one or two things. So Edgar, karibu sana, just to come and close on this CME for today. Thank you.
All right. All right. Thank you. Thank you very much, Eric, for that very insightful session. Yes, I can see just hand claps in the chat box. Very nice, very nice. Thank you very much, Eric. Thank you everyone as well for making the time to join. Um, yes, especially with adulting these days, things are challenging. But we thank you so much. We'll be having the next CME on point of care ultrasound in the next 2 weeks. Again, we encourage you to get this information in a holistic manner. The information is a lot, may not be possible to fully cover it in the period of 60 or 55 minutes. So we encourage you a lot to do the whole training. The training is called pre-hospital trauma life support. We do cover everything as regards management of trauma patients in a very in-depth way. Yes. So yes, just to mention on the CPD points, medical officers will share CPDs tomorrow. Yes, we'll share CPDs tomorrow. The manner in which to claim CPDs, we'll share an email highlighting the specific steps. So one, you must have registered. Two, you must have made this payment of 100 shillings. And then three, you must have been in the CME for at least 20 minutes. Because sometimes we have participants who maybe just join just to appear as though they were inside and then go away. But yes, as quality care, we're really trying to improve on knowledge and skills. So just those three requirements. Medical officers, you'll get a claim code. Nursing officers, you'll get a certificate to upload on the NCK portal. And clinical officers, we request that you come physically. You come physically to our offices along Gong Road, 5th Avenue Suites, 8th floor at Quality Care. Let me just share it very quickly. Do I have it? No, no. Yes, maybe. Indeed, I do. Yes, this is where we're located. In case you'd also want to come and say hello, or say, tell Eric is doing a very good job in person. This is where we're based. This is where we're based. Along Gong Road, just before KNH, 8th floor at Quality Care. Yes. So if you are a clinical officer and you are interested in claiming your CPD points, please come over here. We will stamp your logbook and you will get your 5 CPD points. Yes. Having said that, we thank you so much for making the time. We hope to see you in the next one. And also just to mention once more, in case you are working in a hospital that would benefit um, from these capacity building CMEs, knowledge sharing CMEs, could be on trauma, could be on point of care ultrasound, could be on pediatric life support, adults, BLS, ACLS, any of these topics. We encourage you to encourage members, invite us over, let's have the CME. And hopefully, as we empower each other, then with time, will be the golden standard. Maybe East Africa, Africa, the world at large, when it comes to the provision of emergency care to our dear patients. Otherwise, having said that, have a great evening. Email for claiming of CPD points will be shared early morning tomorrow. Please do the process as soon as possible. Claim your CPDs as soon as possible so that particularly last minute where maybe you're calling me at 11:30 at night saying that you want to renew your license and you need your CPDs. So the sooner, the better. Yes, thanks so much and see you in the next one. Goodbye.